All right, thank you very much. Now that you've gotten some background in what decompression sickness is and sort of how it happens, the next phase of this evening's presentation is really about, so what do we do with it in the field? How do we address it, and how do we address it constructively? So to begin with, yes, let us get to a quick little definition. This was addressed earlier on, DCI versus DCS versus AGE. A small little bugaboo for me is differentiating these terms a little bit. Decompression illness is a nice umbrella term that encapsulates both AGE on one side and decompression sickness on the other. I like to separate those two out, not because the end game treatment is different, but because the front end management might be different and their presentation might be different. And there's a few things that make me approach their management in the acute phase differently. So decompression sickness, of course, is a result, as we've heard, about inert gas load. And arterial gas embolism is bubbles in the arterial system, and usually the onset of this is much more acute versus decompression sickness, which tends to be more delayed. Decompression sickness, as we've just sort of heard, is a probabilistic condition, which means that there is a probability anytime you shove a tank on your back and jump in the water of getting it. I like to ask this question of divers: is there any way that you can get decompression sickness sitting in this room? Pretty much no is the answer. Yes, I'm nodding my head yes, but no is the answer. That's humor. There's a lot of it going on in this talk, and I hope you will laugh. Pardon me? Change the pressure in the room, yes. So long as the current laws of physics exist and maintain, then no, we shouldn't be able to change that around. So the primary determinants are depth, time, and gas mixture. We just talked a little bit about hydration status, and a lot gets talked about. The Divers Alert Network fields about 12 to 15,000 calls and emails a year, and a lot of those calls and emails are about people who get injured or thought they were injured or want to talk about a story of when they were injured, and they go, you know what, I think I got bent because I was dehydrated. How many of you can get bent by being dehydrated? 0 is the answer. Dehydration and decompression sickness do not exist in the same universe. Now, just as you guys were just talking about, it might be one of a multitude of causative or influential or contributing factors. Again, the discipline that we use as divers or as diving medicine physicians is really very, very important. The language that we use about these things is so critical. And symptoms associated with decompression sickness are the result of bubbles and the knock-on effect of an inflammatory cascade. Most of us, and certainly me as an open water instructor back in the day, was thinking, right, this is all about bubbles causing clogs in blood vessels, and that's the thing. All I got to deal with is the bubbles, and it's neat, and it's beautiful, and it's just about bubbles in blood vessels. A few of you are probably familiar at this point in the game that the issue about decompression sickness is associated with bubbles, but there's a lot more to it. So who has here heard of endothelial tissue? Everybody who's in the medical world has all heard of endothelial tissue, right? So endothelial tissue is the tissue that lines our blood vessels. Very physiologically active. Those bubbles irritate that endothelial tissue. It creates inflammation. Is that inflammation in one tiny little spot, or mightn't it be somewhat systemic? So we can have localized inflammation that is most irritating in one particular area, or it might be all over our body. So it's that inflammatory cascade. How many of you treat divers, within an hour of them becoming symptomatic? Almost none of us. A few of us do, but often many of us, and we are very honored, and I'd like to take a quick moment to embarrass him, and I apologize for ever causing a mini embarrassment, but it is because I am so privileged that he is here, is Dr. Elmer Mejia, who is here from Honduras. For those of you who are aware of the Harvesting Diver project that Dan has been working with, Dr. Mejia treats the Harvesting Diver group of the Mosquito Indians, and he has seen more severe decompression sickness, more severe neurological decompression sickness than all of us combined for the next 40 decades of our lives. He sees about 120 cases a year. Most of us haven't seen that many severe DCS cases in our lifetimes. So we should be changing places because you're my hero. But he sees these folks 4, 5, 6, 7 days out sometimes. They're a couple of days out on a boat. And that's how long it takes for them to come back in and get treated. And yet he's still effective. Are there any bubbles left that many days out? No, but there's still that inflammatory process that's going on. There's still some other physiologic knock-on effect that's going on. And that's a lot of what we're doing. So it's important to recognize that this isn't just about bubbles and just about inert gas, although that's probably the kickoff. So what's the big deal? Is decompression sickness common? Not really. How many people die every year of influenza? Got a ballpark? In the US? Somewhere between 30 to 50,000 people. Wow, that's sobering. Flu, everybody gets some flu, don't they? Little flu here, little flu there. It's good for the whole family. Decompression sickness doesn't really kill people, but it's important to recognize some of the incidence factors. So overall, all cases, we hear about 2 to 4 cases per 10,000 dives. Not a rip-roaring incidence rate. When we break that out to a couple of different populations, and I don't want you to look at water temperature as the primary differentiator here. I just want you to think about these as a couple of different study populations who happen to be diving in different parts of the planet. One is warm water liveaboards, so they're diving off the Caribbean and out here. They're diving sometimes 4 dives a day for multiple days in a row, and their incidence is really low. That's somewhat counterintuitive. And then you got the heroes up there at Scapa Flow. Who knows where Scapa Flow is? Is it warm water? Kind of balmy heat wave kind of, coming through there. That's the northern coast of Scotland. Bloody cold water. So these guys are actually pretty proud of the fact that they've got a higher incidence of DCS. They're like, all right, we do manly dives. So they're up there. Now, but the work up in Scapa Flow is quite different than the work on a liveaboard. So these are deep technical wreck dives. So this is a very, very different population. But overall, that kind of gives you a ballpark sense. There we are. So symptom onset of decompression sickness. This is straight out of the US Navy manual. This is an important thing when we're talking to patients because so much of decompression sickness is all about the history. It's all about their story. What kind of dive were they doing? When did their symptoms start? And a point I'd like to emphasize is not when the symptoms became so annoying that they arrived at your emergency department, which might be 2 or 3 days later. It's when they actually started after the last dive that's important. So these are times after the last dive. Do you notice something that symptom onset after the last dive of greater than 24 hours starts to precipitously drop the likelihood that this is decompression sickness? I think that's an important piece. Where we see a somewhat of an exception to that little rule is when people are flying after diving. So sometimes we see people who were pretty asymptomatic and then they have an additional decompression stress of flying, and sometimes that can extend that period out a bit. So don't totally close the door, but have a little level of suspicion. Swear the clicker doesn't like me. There we are. This is some great DAN data. I really love this table. This is also in our newest oxygen manual, and it talks about the symptoms associated with decompression sickness. And rather than just throwing them up there at a chart, which is sort of a hodgepodge, which gives you almost no useful information, this lets you know that when you're staring at this, a symptom like pain is the leading primary cause. So the dark green is all symptoms, the light green is first symptoms. So this is one of the most common first symptoms is pain, followed by numbness and paresthesias. Now, Dr. Mejia sees a lot of guys out here who have bowel and bladder problems. He'll see a lot of people who have motor weakness, lower extremity paralysis. So just because it's not common does not mean that it can't happen, but it just gives you a sense for what you might anticipate. I'd like to say a little something about symptom onset, what I refer to sometimes as disease tempo. Things that come on soon after the dive tend to get more severe more quickly. That makes intuitive sense, I hope. Somebody who's had mild symptoms that come on 18 hours later, it's very likely that that sort of the graph would be very flat. very minimal. These will be somewhat equivocal. These are the folks that have shoulder pain, and you're like, gosh, was that because you were heaving your tank in your bag after the end of a day, or might that be decompression sickness? How many of you have gone, geez, you know, it's a bit of a coin toss. Why don't you just come in the chamber because it's 3 in the afternoon and you were kind enough to come in during the light of day as opposed to 3 in the morning? Anybody? Right. If you haven't, then you're really not in the game, because all of us have gone, you know, sure, come on in, the water's fine inside the chamber. The overarching treatment goal of decompression sickness, I guess we're going to have to wait for it, is our goal is to primarily treat as soon as we can after symptom onset. Does that mean that if you don't treat right away, the world's going to end? No, the world's going to end, I'm sorry. I don't know why it hasn't happened yet, because again, that's really humor. It's not really very funny, probably. No, the world is not going to end, but ideally we would like to get those people in the chamber sooner rather than later if we can. There's a little data on this, and the primary prognostic indicator is symptom severity. Anybody got a sense of some symptoms that really indicate the world has gone into a very bad place? All of the excrement has hit the rotary oscillator, and for those of you who don't speak English, I'm sorry, that's the crap has hit the fan. A nice little term around here that all things have gone in a bad direction. Any indication of what symptoms might indicate a very poor prognosis, regardless of when you treat them. Even if you got them right out of the water, they had symptom onset and you got them right into a chamber. The rotary oscillator is hit by fecal excrement with things like lower extremity paralysis and urinary retention. Bad, bad symptom, bad prognosis. Dr. Mejia will tell you that in Honduras, and forgive me if I'm paraphrasing here too badly, that the poor divers there who wind up getting urinary retention, require self-cath, wind up having about a 2-year life death sentence, about a 2-year life, because they wind up with urosepsis at some point. It can be a horrible, horrible aspect of this condition. So symptom severity is a big one. So the flip side is also the case. So if you've got very, very mild symptoms, you can have and tolerate longer delays without having a significant impact in the efficacy of your treatment. So early treatment is associated with better stuff, especially in severe cases. And SLO2, that's surface level oxygen. That's the oxygen that we would provide here, emergency oxygen in this room, might be protective. So if you know it's going to be a long delay, you can actually minimize the impact of that delay by giving someone surface level oxygen. Yet another reason to think about what a great idea that is. So what are our treatment options? Well, we have surface level oxygen and fluids. This is my favorite box. That's why I've colored it green, because it's always a good idea. If you want to know something in life, and there are very few things that you can always do and go, yep, I can just turn my brain off and that's always a good idea, that's pretty much it. Give someone oxygen and perhaps give them some fluids. Fantastic way of doing stuff. When we get a call from somebody who's off the Cocos Islands, which is about 36 hours away on a boat, who's symptomatic, I can tell you that they don't have a chamber on board, but they oftentimes have fluids, oftentimes IV fluids, and they have oxygen. The last time I got a call like that, I was very pleased to hear that they had a British trained doctor, so they had somebody on board who could actually start an IV, and that's also a joke for those of you who train in the US who have no idea even what an IV needle looks like, and was able to give that person some IV fluids and oxygen, and it was nice to hear that they got a lot better. The other alternatives here, and I will talk a little bit about evacuation. That's sort of where the first aid world might live. The portable chamber use and in-water recompression are beyond the scope of this talk, but they are other tools potentially in the tool shed for particular environments. So initial management's always surface level oxygen. And the answer to how much should I bring is enough. So we get this question not infrequently from boat captains, and they say, well, how much should I carry on my boat? And it's a pretty easy rule of thumb. Let us say, for sake of argument, that it's about an hour commute from where you're diving off the islands back to the boat. You at least want to have an hour for one person. It's nice to double that because you might have two, and it's nice to give yourself a little extra padding. Why? Because EMS isn't necessarily right there. You've got probably a nice half hour or so pad in there. So that all of a sudden becomes about 3 hours worth. Sort of a nice thing. How could you increase the duration that that oxygen provides? You can use a demand valve. If you're using a non-rebreather mask where you're blowing oxygen like mad, you're going to run out of O2 pretty quickly, and it's hard to have that kind of volume on most boats. Please work. There we are. Fluids. These can be PO or oral fluids or IV fluids. And evacuation. Anybody know what this thing is? This is an SOS chamber. I'm not trying to promote anybody. It just gives you an idea of an example of a portable chamber. Having been in one of those things, I think they come with a family pack of Valium so that people can sustain themselves in there. A guy like me doesn't sustain himself very long in a chamber like that. Now you can, because these are actual, no kidding, chambers. You can do a treatment table 6 in one of these things. You could keep somebody in there for 5 or 6 hours. You might have a stark raving mad human being at the end of that, but you could actually put him in there for that amount of time. Why do we evacuate people? We evacuate them because there's a mismatch of who they are, what their clinical condition is, and what we can provide. That's really the short answer, isn't it? It's actually pretty simple. So if we have, all the king's horses and men to put Humpty Dumpty back together again, we can feel pretty confident that we can treat them right here. If we don't have that and that's what that person needs, we should get them out to where they can get that. But what are some operational considerations when we consider evacuation? And there's a lot. It's kind of fun to use PowerPoint, isn't it? You get all these kind of cool diagrams that are prepackaged for you, but you've got their patient status. So are you going to shove somebody who's unstable onto a commercial flight? That's an obvious disconnect. No, you're not. What's weather like? If I'm up in Alaska, I might want to evacuate people, but there's a blizzard outside and the next boat's not going to be in for 3 days. I guess I'm out of luck. There isn't, the helicopter isn't going to come in because it's not safe for the helicopter crew to come in. What's the impact of delays? I'm going to do the best I can with whatever I've got. What's the distance? That's obviously going to be a factor. Local assets, time of day. So do airstrips work 24/7 around the world for every airstrip? No. So not infrequently, we're faced with trying to air vac somebody, and they give us a call at 5:30 in the evening. And we go, yeah, about that evening thing, because there's no lights on the landing strip. We're going to see you tomorrow morning. The pregnant pause that's in this room right now is the same one that's at the other end of the phone, because it's a little bit horrifying. You're like, what do you mean the Marines aren't coming to pick me up? No, I'm sorry, there isn't such a group. So we're going to have to wait for tomorrow. So the sooner you can get resources and help activated, the better. What's your certainty? How many of you have treated decompression sickness and you've been pretty much like this about whether that's your diagnosis? You have to be if you're treating this, because there's no diagnostic certainty on every case. So before you mobilize an evacuation service, you want to hopefully have some sense of what you're treating and why. And then, of course, your evacuation method is this: ground, sea, air, etc. If you're going to do this, I hope that you involve somebody who's done this before and you've mobilized the resources that are necessary. I can tell you that in some regions of the world, when local assets try to take on the responsibilities that Dan tries to take on, and this is not a plug for Dan per se, it's just, it doesn't always go very well. And we wind up playing catch up, and people's insurances and how things get paid for really get screwed up. So engage somebody who's knowledgeable, or some buddies that are knowledgeable. Maintain as much high inspired oxygen fractions as you can, fluids if possible, and whatever medical support's necessary. So this might be an air ambulance, or it might be commercial air. A little plug I'd like to say, and this sometimes gets people confused. Occasionally people call us up and they go, hey, listen, I've got this guy, he just got decompression sickness at the lake, and he's at the local tarmac. Can you please fly him to the next state over and get him treated? What do you guys think the answer is? So, no, I can't. How do you say that nicely? Sorry, can't do that. Your local EMS protocols actually says, please go to the nearest hospital. That's what I want you to do. Why? Do I always know that this is decompression sickness? How many neurological problems have people seen related to decompression illness relative to, say, something like stroke, relative to a transient ischemic attack? Could there be another diagnosis on that differential list other than this? And wouldn't you like them to be evaluated before you just put them in a chamber because they happen to be wet and diving? I don't want you to turn your brains off or allow other people to turn their brains off just because you're dealing with a diver. All right, so symptoms on one column, decisions on another. These are color-coded. Red, not a bad decision, but something that I want you to pay attention to. Red would be the equivalent of brain surgery. Brain surgery is the right thing to do under certain circumstances, not the right thing to do unless you're a neurosurgeon in the right kind of medical facility. Would you generally agree? Certainly, if I ever need brain surgery, I want it done in the right place under the right circumstances. So there's a higher level of concern here. So for mild symptoms, you always are going to have surface level oxygen and fluids. You may or may not need evacuation or hyperbarics. I know, heresy. You might not need hyperbarics. In a mild case of decompression sickness in a very remote location, surface level oxygen and fluids may be very appropriate. So, and delays in this environment are unlikely to impact outcomes. Moderate symptoms. This is sort of the sweet spot for a lot of things. We're going to still do the surface level oxygen and the fluids. Hyperbarics really comes into its own here. This is a place, if you're in the right environment and you have the training for portable hyperbarics. Evacuation, certainly, if you don't have the right facilities or you don't know what you're doing. And, although I'm not going to talk about this, for those people who have gone into that whole thing, this might be a potential tool in the right sorts of hands in water recompression. And for moderate symptoms, delays of less than 6 hours are unlikely to impact outcomes based upon some of the data that we have. The data is not, of course, all that controlled. It's a case series stuff, but it's not terrible stuff. Severe decompression sickness. This is where we have to put our thinking caps really on. Oxygen and fluids are always a good idea. Certainly, we're going to try to rope in hyperbaric medicine. Supportive care, because these people are likely to have other issues that are going on, i.e. maybe they need a catheter or they might need MRIs or other scans of their brain and spinal cord. And certainly evacuation if that seems to be appropriate for who they are and what they need. Expect residual neurological symptoms, and even with immediate treatment if they're really severely bent. Clear as mud? All right. Our role, and this is not I know this is a CME event, but sometimes people wonder what the heck Divers Alert Network does, and so this is purely for edification. We try to provide good information and guidance on first aid. We try to discuss medical plans with healthcare professionals, either ourselves or through health professionals that we contract with, a representative of which is here tonight. So we also contract with experts at the University of Pennsylvania and University of California, San Diego. And we help to coordinate evacuation. So those are some of the big areas that the Divers Alert Network can help. Some questions for you. You doing okay? You ready for some questions? This is quiz time. This is the really tough stuff. I know you're ready though, because you've been paying such good attention. So emergency oxygen therapy is effective for diving accidents because speeds inert gas washout. Would you agree with that? I would agree with that. Enhances oxygen supply to hypoxic tissues. I'd agree with that. Helps to reduce bubble size by creating a diffusion gradient. I'd also agree with that. And emergency oxygen should be provided at the highest FiO2 possible. Fantastic. Will you accept that that might be one of those all of the above answers? Yes. And last one, factors to consider when planning an evacuation include medical status of the patient, of course, sort of a no-brainer, I hope. Pattern or progression of rate of symptoms? Yes. Of course. Extent of local medical resources to include expertise and medical facilities? Of course. Transportation times, availability of medical skills, and evacuation services. Another one of those all of the abovers. Really try to trick you on that. You okay with that? That concludes my talk. Thank you very much for your attention. Anything? Yes, sir.
Have you seen any relationship between obesity and an increased incidence of decompression?
Great question. For those of you who couldn't hear, what's the relationship, or is there one possibly between obesity and the incidence of decompression sickness? Was that a reasonable retool? Okay. So we're at the receiving end of a lot of calls and emails. And so I don't have a monitor on body habitus, on BMI, on what anybody looks like. So it's a little bit difficult for me to say from where I'm sitting. What I will say is that from many of the cases, and this is anecdote, so please take it with some salt, that many of the cases that we hear about with cutaneous decompression sickness, skin bends and lymphatic bends, tend to be with people who have more adipose tissue. And those areas of skin DCS tends to be in the truncal areas, abdomen, buttocks, chest. So if one point on Dr. Strauss's talk, when we talk about slow and fast tissues, when we talk about this really from a decompression model from a computer, it's not really differentiating actual tissue compartments. These are purely mathematical algorithmic tissue half-times. So when we compare those then with types of tissues that are likely to be fast on-gassers and fast off-gassers, so we make a rough connection between those two. Fatty tissue is not remarkably well vascularized, but it has a potentially large ability, although slow on-gassing time, it's going to be a slow off-gassing time. So people who have more body mass that way, more adipose tissue, are potentially more likely to have more issues, especially if they're doing multiple dives for days. Any point on that?
No, I had another question.
Oh, you had another question. Well, that would be my answer to that.
Yeah, lipid.
On that topic, there actually is a little bit of data on that. Very old data from the Navy. When the Navy was developing their dive tables, they were bending their Navy guys.
Sorry, ladies and gentlemen, this is Dr. Chris Logue from the University of Pennsylvania.
And what they did was they looked at, they didn't call it obesity, they called it linear density, height to weight ratio. And there was an increased incidence with height to weight ratio. The problem with that was that there's complicating factors, that the older divers tended to also have the higher linear density. So there is some data, there's some very old data on that, but if you want, I can find it for you.
There's also some Air Force data with respect to decompression in hypobaric chambers. So there was an old article, the Haymaker article, on some of this stuff, which is fairly fascinating. And they found that the pilots who wound up having decompression sickness, and some of these guys really had very bad decompression sickness, tended to be bigger guys. So there does seem to be some association. Dr. Strauss.
Well, we know from chemistry that the solubility of nitrogen in fat tissue is 5 times as great,
right.
as in lean tissue. So it would be like a sieve to absorb that nitrogen. But the question I had, you're confronted with a situation where the diver has, for all purposes, decompression. So you can say pain only, and then you do the surface oxygen, and they become asymptomatic. Do they need to be treated? I have my own algorithm. I'd like to hear what you, Dan, espouse.
I'm going to actually separate myself from the Divers Alert Network for the moment, because we don't actually have a policy on these sorts of things. I will say from my own experience on these things, both neurological symptoms that were present and went away, same as pain only. My biggest concern is especially in neurological DCS, more so than if I have to take all comers. Our greatest concern is in neurological decompression sickness. When people have a history of neurological decompression sickness especially, and I'll now lump in pain as well, and they have resolution with surface level oxygen, that makes me feel good, but it does not mean that I don't think that they should get treatment. Why? Because I hate hearing about recurrence of symptoms. And when people tend to have recurrent symptoms, especially with neurological decompression sickness, the general feeling is that many of these are a little bit more recalcitrant to treatment. They're a little harder to treat, and it really makes me feel bad, like we dropped the ball. Like, we could have treated them when we were really on the heat of the hunt. And so if they're coming to your emergency department, don't go, right, you look great now, I don't care what happened earlier, and just blow it off. That's probably... I have a slide actually in one of the talks that I give that has a big great white shark. And to me, a history of neurological symptoms in the case of decompression illness is akin to chest pain for an emergency doctor. The reason I say that is chest pain for emergency doctors is their greatest liability. It is if they miss the heart attack and they send somebody home and they wind up having a heart attack, that's where most ER docs get sued. for us, this is, and I'm not worried about the liability thing as much as how are we doing the right thing? And are we doing the right thing? One treatment might be just enough to keep them resolved and make us all feel a lot better. Does that